Button. All right. So welcome back to the LabCOP. It's been almost a month since we last met. Um, and we've got a couple of things on the agenda. Um, One is the uh, NHSN stuff. I don't remember what the urine culture results for HAI requirements were, but do we have a update on record bottle volume from the meeting with BioMérieux, which unfortunately I ended up missing?
Um, that was a month ago.
Yeah, something like
Um,
that. Yeah.
yes. And it can be done. They'd be happy to work with us. But yeah, it records volume. And that's what I remember right here. They
Okay.
don't have a way to document that, like the laboratory has to document it, um, from what I recall. It doesn't have any particular code. We would have to come up with that. Um, but they're more than happy to continue working with us.
And do you remember if it was for one bottle or for the set of bottles?
It's for each bottle.
Okay.
And um, there's some way that it happens. Laser? I'm not sure exactly how, but it's each bottle. And they haven't designed a way for laboratories to code it and report it. The laboratory does that on their own. So that's where we could be of help and where they would like to be of help.
Awesome. And we've got a new member on, Richard. I kind of you know, opened this up for or talked about this on what call was it? The newborn screening call, right? Was it? No, the Astro call. Sorry. Or which one was it, Richard? I forget.
Um, we had our own call. It was just me, you, and Nicole.
Oh,
Um,
that's right. That's right. It's
yeah,
the Carious thing.
yeah.
Yes. Okay. Sorry. Thank you. Okay. So that's the next topic. Um, we were just doing some some follow-up items here, and then that's the next topic. Richard, sorry for
Perfect.
mixing up all my calls I'm on.
You're good.
So,
Um,
Richard, can you tell us where you're from? And
Yeah, sure. I'm from Florida. I'm the ELR epidemiologist for Florida, so I deal with a lot of um, kind of the bioinformatics part of like translation of the different coding into our surveillance system and making sure all that is processing correctly, and then also deal with onboarding new facilities or re-onboarding facilities that we are currently with to improve data quality in their SNOMED and LOINC coding for the tests that they perform, and to make sure everything looks good and will process in our case surveillance system appropriately. Um, yep. So that's me. I've been
yeah,
with
and
DOH.
so
Yeah.
you know who else is on. I think we're gonna do a round of introductions here. So Nancy, do you want to go next?
yeah, my name is Nancy Cornish. I'm a pathologist and clinical microbiologist. I work at CDC in the Division of Laboratory Systems. Right now, I'm deployed to hantavirus and Ebola EOC, so Emergency Operations Center activations. Um, and I was in clinical practice for about 20 years before I came here. Um,
And you're the co-chair for this call with me.
and I'm the co-chair for this call. It's nice to meet you, Richard.
Yes. Thank you. Nice to meet you as well.
John, you want to go next?
Sure. Hi, Richard. I'm John Snyder. I am currently the U.S. author for all of SNOMED for the United States, and I work for National Library of Medicine.
Nice to meet you.
Amy?
Hi, I'm Amy Liu. I work for Inductive Health as a contractor to APHL, and I work mainly on SLIP and VPD programs, and I'm here helping out as needed.
Kathy?
I work at LabCorp on our specifications, mostly things in V2. Um, though we're, I guess, trying to go into other things now, but that's it.
Yep. And Christina?
Hi, my name is Christina Gallegos. I am a terminology specialist. I'm on Ricky's team. We met on the Kairos call on Monday. So happy to have you on this call to talk more about the Kairos stuff.
Awesome.
So that's actually our next topic. So we'll hop right into that. I have to reread what uh, JIRA feedback we wanted to do. We have that in the notes from last week, but I forgot to finish my thought here, and I don't think we need to talk about it because we talked about it, but somebody needs to do it. I just didn't want to lose it, so I put it in here. Um, okay, so I don't know if everybody is familiar with Carius and how they're testing. Um, John, Kathy, Nancy, or do you know what kind of tests Carius does?
Oh, it's been a long time since I reviewed it. They're doing like multiplex testing, aren't they?
Yeah, they're looking for multiple different DNA and RNA
Right.
sequences in whatever I guess cell-free plasma and bronchoalveolar lavage.
Okay. Um,
And so they're starting to onboard with Florida Department of Public Health for ELR. And that's when, Richard and his team reached out to us because they don't think that they're using the right lung codes necessarily. And we may need to submit for a new one if we don't find one.
hmm
But also really what they wanted to talk about is the result types, because right now, and I remember when they originally came on, we worked with them, and I think we made sure they got this loin coat actually, um, is what they're using for reporting, which I think is the correct loin code. Um, but um, but at the time, and how it's mostly set up in laboratories these days is that the value set for reporting results back usually draws from SNOMED out of the organism hierarchy. A lot of LIS systems can only support drawing from one hierarchy, so um, you know, so they are reporting this as organisms, and I guess they could find some organisms that are maybe on the select agent list or something like that. So I guess CDC reached out to them and said, hey, what's going on here? How come you're reporting these organisms when they're not growing them or anything? They're just finding their DNA fragments or
Right.
RNA fragments. And so there is a desire by Carius to actually use SNOMED codes from the substance hierarchy. And so um, that's kind of what we want to talk about
So,
a little bit. And Richard, go ahead. You have more
well,
of the
can I jump in, Ricky, real quick?
sure.
I guess the challenge I have here with using the substance concepts is that state reportable labs are based on the organism and not based on the DNA
Mhm.
or RNA substance from that organism. And there's a disconnect in SNOMED where you can't connect the substance concept representing the DNA or the RNA back to the originating organism concept so that organizations can directly submit for state reportable labs for communicable diseases.
Mm.
So what I guess my question is what's the end goal here for the appropriate use of SNOMED?
But yeah, that's what we're trying to figure out, right? How should we, what guidance should we provide for Carius? So,
Yeah, because I think that because this is like metagenomic, like next gen sequencing, and I think that in the future, um, this is going to be a lot more prevalent going forward. I
Mhm,
mean, obviously not immediately, but I think it will become more prevalent over time,
mhm.
and I think that we just will need a way to navigate that when more facilities or more companies start utilizing metagenomics, mainly for how quickly they can identify stuff and the number of organisms they can identify or pathogens they can identify with just a single run. And then once that starts happening and things start becoming commercialized, we're gonna have a need a way to ingest it in a way that makes sense. So I
So
think,
the goal for CDC and state reportable for organ is still the organism concept. Is that correct? It's not the substance for the DNA or the RNA. Is that correct, or has that requirement changed? Because I know under meaningful use stage two, the state reportable labs required organism concepts, not substance concepts.
yeah, Florida doesn't consume any substance concepts for our reportables as of like
Hmm.
currently. Yeah, we just everything is through organisms.
Okay.
But the only time that we're receiving organism snowmeds is for cultures. So we don't receive organism snowmeds outside of culture testing.
Okay.
Yeah.
So I guess mm, we're SNOMED's currently working, the US is working with Australia to promote the creation of an attribute that would link the substance hierarchy to the organism hierarchy.
Oh.
So that you would actually be able to programmatically make that connection from the DNA or RNA substance or the antibody antigen substance to the actual organism that it originated from.
Hmm.
That's currently in the works. So what I would say is short term is going to require the curation of an organization specific map between the two hierarchies, with that short term plan being replaced by the longer term implementation of the attribute that you could then programmatically make that association just using the terminology.
Okay. Do you know what the timeline looks like? Like how far along they are with that?
We've been working on it for a year now, and we just updated the proposal. I actually just emailed Australia with comments on it earlier this week. So
Oh, cool.
I can't give you a definite estimate as to when SNOMED International may adopt that attribute and
Mhm.
actually implement it. My guess is, based on the speed we've been moving, we're probably still about a year away.
Okay. Gotcha. I mean, that's reasonable. I mean, like I said, this testing isn't going to explode in a year anyways.
Mhm.
I mean, they're all still LDTs. No one's commercialized that I know of. So, it's right now, I think it's only a few. I've only really seen a few labs that have sent us lab results that are this type of metagenomic NGS lab type. And
Mhm.
usually they're sending us paper labs anyways. It's just
Mhm.
that Carius wanted to onboard, but I think it makes a lot of sense to obviously have those connections prior to creating a bunch of stuff that you can't even that most systems won't even be able to um, point to
Mhm.
an organism. So um, I think it would make sense to wait for that, but I do think it would make sense to use substance codes for this specific testing, just because of how historically SNOMED codes have been used, or organism SNOMED codes have been used historically, for isolation rather
Mhm.
than just some type of protein or whatever.
Well, I guess my only question on that is does that fulfill the mandate though from the CDC or from the individual states for the testing?
I know that Carius, once they got in trouble with, well, not in trouble, once CDC was like
Yeah.
kind of questioning them on all their getting these, select agent positives and being like,
Hmm.
hey, send us these organisms, and them being like, we don't have that. I know that they, I think Nicole said that they since then have gotten a lot more like understanding with how they're reporting currently. So I don't think it's a
Hmm.
huge problem with CDC as of right now. Um,
Okay.
but with the different state reportings, I mean, Florida's a little unique in the sense that our surveillance system is we developed it ourselves. Like we're not using like MBS or any other like national standardized reporting system. So we have a lot
Hmm.
of flexibility on how we process labs and how we can manipulate the data coming in as well. So for us, it's not a huge deal to wait, but I don't know what the other requirements or the other limitations for the more standard reporting systems or surveillance systems are nationally.
I mean, the reporting requirements, right, are to report the detection of or
Mhm.
the suspicion of, in some cases, specific organisms. And so if you're, finding their RNA and DNA,
Mhm.
it's an indicator that there's probably an organism there, but,
For sure.
it's not necessarily the organism available in the lab, right? And
Right.
so people have traditionally for other instances also used the organism hierarchy, like for antigens, for example, right? When you're
Yeah.
detecting the antigens with some of the tests, if they are not if they have nominal answer lists, right? um,
Yeah.
People still use the organism concepts for that currently because of the limitations of a lot of the commercial systems not being able to actually create value sets because I think the from different hierarchies because I think the manufacturers that provide these systems they you know create simple
Mhm.
value sets and don't really unfortunately utilize, a
Yeah.
proper value set definition model and things like that. So, um,
And I think there's still going to be challenges for the state and CDC because in some cases, Link carries the context of the source
Right.
of the
mhm.
DNA, and in
That's what
some
we do.
cases, the SNOMED is carrying that context. So there's always going to be some level of ambiguity that needs to be dealt with at the analysis level.
Yeah, or it's a combination of both, right? Like in this
Right.
case, or
Hmm.
in the case of
Correct.
the antigen tests with nominal results, right? Because
Right.
the one will tell you they're looking for antigens.
Yep.
Um,
So can I ask something? Because
uh,
I'm concerned about this test. I don't think it's FDA approved, right?
No, it's LDT right now, so it's just
Yeah.
CLIA. It's just CLIA waived, I think,
Um, CLIA waived,
or not
really?
waived, CLIA waived. It's just not FDA approved now because it's not
Yeah,
commercialized.
right. Because it could just be detecting a small fragment of DNA
Right.
and there is no organism.
They quantify it though.
Well, yeah, but still, I mean, we all carry fragments of DNA
Yeah.
and RNA
Yeah.
in
I don't
our
like the test.
bloodstream.
Personally, I'm not. I don't like the test personally.
Yeah, I mean, I'm concerned about it because I feel like it'll mislead people. Um, y- so and result in overtreatment. Um,
Mm.
so, because physicians who order it will think when the answer comes back, oh yeah, I got to treat this patient. Um, so, okay, well, so are we don't want to LOINC and SNOMED code this the same way as we would for an actual organism. Is that the thought?
I mean, to be semantically correct, they are not detecting the organism.
Yeah.
They're
Right.
detecting the RNA
Yeah.
and DNA, and that's what they should be reporting.
Right.
Um,
And
uh,
maybe only fragments, not all of it.
So if you
correct.
detect that, would it reflux back to another test that would
They
identify the
don't, they don't,
organism?
this is the only test they do.
Hmm,
So,
understood.
so so if the sample, for example, is sent to a lab and the lab sends it out to Carius, for testing, and the Carius result comes back with a fragment, the lab that has the original sample may do those testings, but Carius can't do other testing. I think they're only doing this kind of testing. And um, I could be wrong. I mean, that would be a question for Carius,
Hmm.
but I don't think they do other reflex testing. And sorry, Nancy, you have your hand up.
Oh, I put it up, but
Oh, okay.
yeah, let me put it down again.
Okay. Um, but um, but yeah, so I mean, I also am not a fan of this tests per se, but I was just at ASM 2 weeks ago, and there was a case report where, they had tested for pretty much everything, and everything that they were um everything they had tested for came back negative, but the patient was really pretty sick, and so they sent it to Caries and they found something, that way. And then once they knew, to look for that, or they treated based on the Caries report. I don't remember off the top of my head which way, but so it's like for those rare cases where you can't find anything else
Right.
and you're just throwing the kitchen sink in, to get something because you want to figure out what's going on with your patient. Um, I think that's where it probably does have some
Well, and
validity, but
the other thing I'm not too keen on with this type of testing in general is that because it's not commercialized and isn't FDA approved, the cutoff values for the like what they consider to be abnormal or positive for a organism, like typically with PCR and targets like that, like those have gone through studies and like there's they're comparing it against like culturing and other types of things to find those cutoff values. But I feel like for these types of testing, there's no standard um, in terms of the comparative like reference ranges of like the
mhm,
individual organisms, and I think that's a problem as well. But because it's an LDT, they're not sharing that process with anyone that I know of.
mhm.
So, yeah,
I mean, I'm sure they've done some form of validation,
yeah,
otherwise they
for sure.
couldn't do
Yeah,
it,
yeah.
but
But I think like from one metagenomic NGS test to a different one, like they're all a little different. And I think they also do it based on each run as well. Like they look at the noise versus what's actually what like the copies that are like coming in as the test running. I think so. I think the calculation happens per run per like target.
hmm,
But
interesting.
yeah,
I
but I
mean,
just have a
it's
feeling.
been a minute
Yeah,
that I've looked at this test, but
Right. And, if somebody's severely ill and they can't find a cause for it, whatever they find, if they run this test, they're going to make the assumption that that's the
right,
cause, and it may
mhm,
not be, you
right.
mhm,
know. Um, so yeah,
Yeah, and it may be the case that you do this test on a healthy individual and 20 things pop up, and you're
that's
like, wait,
right.
the person's fine. Yeah,
mhm,
Hmm.
yeah.
Yeah. So
yeah. I'm not too keen on it. We just need a way to consume it.
how often is it being run?
We probably get uh, maybe a couple a month, maybe.
Okay.
So I don't know how often it's run like they're running because they report also to I think a few other jurisdictions like California and but Florida we only get like maybe a couple a month, and then I always get and then it comes to me immediately. And they
Okay.
go, "Hey, what do we do with this?" And I'm like,
Uh,
yeah,
okay. I'm so
yeah,
sorry.
But I think that if we do go the substance route, that at least that is a it's different than just an organism SNOMED. So maybe that will hopefully key people to be like, hey, this is different, maybe, or like this isn't the same as like, isolating an organism in a culture. I mean, I don't know, but
Yeah.
I'd also be interested to see gaps in the substance hierarchy of
Yeah, I
what
mean,
it
there's
is you're
there's a
definitely going to
lot.
be
finding
There's
and
a
some, yeah.
lot. There's a
yeah,
lot. It's huge. It's a massive.
yeah.
And that was the thing is like we would have to you'd have to create like probably a few thousand like substance codes, I think.
So is this, I forgive my ignorance, is this closer to a MALDI-TOF type
No,
test?
no, no,
No.
no, no.
Okay.
MALDI-TOF is looks at like ribosomal weights, and this is more of like you could think of this more like more PCR like than like a MALDI-TOF
Okay.
because they're doing. I mean, they do I believe they do PCR as like one of the steps of this.
Mhm.
So like but yeah, no, the Maldi's a little more because
Yeah,
the
I think
Maldi
they
is
have
using
different,
like
I think
actual
they have
colony.
different target
Yeah,
regions for the different organisms they can detect. But
right.
they're
And
not
like
sharing what exactly that is because that's
right.
proprietary.
And a
So,
Maldi you need isolated colonies, and with this you
yeah.
just put in the specimen, I believe, and they like
Hmm.
clean everything. But
Yeah, it
so
runs on clinical specimens,
yeah,
Okay. All right.
which is
Thank you.
why they don't have any organism to share with CDC when they
yeah,
find,
Right.
you know.
I'm thinking through, I really don't want to add 1,000 or 2,000 substance concepts.
Well, especially, I mean, especially not right now when it, can't be used by a lot of people.
right.
Right. Yeah.
So maybe we go look through the list. Richard, I forget, did you upload it to the ticket yet or?
Yeah, I think Laura uploaded it to the ticket.
Okay, I'll go get it from the ticket. And I'll share that with John and we can go through and find if there are any organism concepts that are missing.
Okay.
But it'll also give you an idea of the substance concepts that we might need for that. And maybe we'll make sure that we have organism concepts for anything that they need to report right now and start with that. And
Right.
then, but let them know that, there is a project going on that's working on that, and then also make um make folks in general aware that this is coming so that they can update the systems to support more than one hierarchy for results. I mean, they should do that anyway because in some cases, they should support organisms and clinical findings, right?
Mhm.
Because those mixed organisms don't really exist. They're really
Right.
findings, right?
Yeah.
So
And
I
there are
mean,
some findings that I mean there are a lot there not a lot, but there are a few that exist already as those findings where it's like this or this, this or this.
right,
But there's definitely combinations that don't exist for sure.
Hmm.
right. And
Yep.
and for some of those, it might make sense to be in the organism hierarchy because,
The
they share an
genes. Yeah.
antigen or
Yeah.
something. And so, if that's what you're looking for, you really don't know, but it's still, in the same Linnaean hierarchy, they're related kind of things like
Right. Yeah.
like the TB complex stuff.
Right.
But in other cases, especially for Maldi, there are different species
Yeah. Like E.
sometimes. And
coli,
you kind of go,
Shigella.
now what? You can't do that in the organism hierarchy. So those are the
Yeah.
ones that really should be in the clinical um, finding hierarchy, and we maybe need to do more education and outreach so that the systems can actually represent the data and not um, have workarounds.
Yeah.
Yeah. The tough part there, Ricky, is one, the complexes are rarely well elucidated in the
Right.
literature, and they constantly are, one reference will include five and miss one, and another reference will
Yeah.
include four and miss one. But also from a clinical findings perspective, because it's a disjunction, which we try to avoid in SNOMED,
Right.
meaning that it's or, I can't actually model it with a causative agent to point it back to the organism to make any type of link. So while it's a clinical finding, its use in analytics is limited.
Yeah.
Right. Yeah.
I really wish the LISs would support multi-maps, but
But
I'll just keep wishing.
have we let them know they ought to?
Well, I mean, that's the thing. I think, this is something Shield could probably do. Um,
Yeah, I mean, somehow, I mean, if we don't tell anybody that there's these issues, then it won't get fixed. It may not get fixed anyway, but at least we told people.
yeah, I know I have brought it up several times, but it's a matter of a lot of changes in HIT vendor systems only happen when the customer asks for it. And only happens when enough customers ask for it if it's a
Yep.
bigger vendor. And so that's really, I think, the crux of the matter. We tell one or two people or one or two customers, and they may ask for it, but if they're one of several thousand, then maybe we'll do it if we don't have anything better to do, which is never. Right.
Right. Or it might happen in 10 years if we at least bring it up.
Yeah. So I mean they do support the qualifiers, but they're usually not together in the same thing, except maybe not detected or negative, and maybe they must have found a way around that because they can result in a culture where there's no organism identified just fine, right? I mean, if they didn't, well, or they haven't actually assigned a SNOMED code for that because that's not reportable. So, in a lot of cases, what I learned, when APHL moved from supporting just the reportables to supporting result exchange in general, is that a lot of labs don't codify their results unless they're reportable, and that codification doesn't happen in the LIS, that happens in a separate system. So there's that.
Mhm.
These are the hierarchies we think people should be supporting for results, maybe. If I can type. Um,
Yeah, because for DOH in Florida, we try to always, or at least because I guess I'm the one that's doing the mappings and everything in our system. I always try to get them to more so use if there is a specific link to be as specific as I can with the link, and then because of those gaps in the the result or the SNOMEDs, then like for like antigen detect, like whatever, like for all those different ones. So
mhm.
I always try to go more specific on the link side as much as I can. But if it doesn't exist, then that's when we
Well, the other problem though with that is that, a lot of the labs, at least public health labs, um, well, maybe that probably applies a little bit more on the specimen side than on the component side, except for cultures. Cultures is kind of really hard to be component specific because they're running,
right,
a culture on one plate, which can grow several different
right.
organisms. And so for them to attach multiple links to this one test and then report those out
Oh yeah, no, that's
individually
we do
is
the
really hard, right? And
yeah,
and
yeah,
similarly, if they do, mostly tests on serum, but they could do that same test on, some other body fluid, or even
Right.
maybe they even have it validated for wastewater or some environmental
True.
sample, right?
Yeah.
Then they're not necessarily setting that up as a separate test, and they can really only attach one loink to a
Right.
test, because they
Right.
don't add the loink for each individual result. They add it to their test menu
Hmm.
setup,
Yeah.
right?
Yeah. For like cultures, we'll use a general loink, and then we'd use the organism SNOMED. And then if there is a test where it's can identify more than one um, analyte in a single test, then we would try to use an identifier loink um, to capture that if they're going to be sending the specific analyte as a result value. But we, but yeah, like you said, yeah, that is also limited. The in specimen loink codes is definitely not as common as the more like in serum or in blood or whatever. Um, but we have what's nice about our system is we have a lot of workarounds. So like we have our hierarchy of processing. We can define specimen types in our loink tables that we have, and then we have hierarchy to look at like the different OBX for like specimen type to set
Mhm.
that in our system. So, but yeah, it's sometimes it's tricky, and you got to do some magic.
Yeah. I mean, Loink is thinking about moving to less pre-coordination in the long run and take out the specimen in the method.
Yeah,
So, and they have been moving more towards assigning broader method method codes, right? So MolGen
yeah,
for any kind of genetic testing,
right,
um, which is problematic if the lab can't report the method separately somewhere, and the receiving system doesn't have that somewhere, because sometimes the method is what makes the difference,
right. That's what's right. Yeah,
right, in the case definition. So
yeah,
anyway, I think we'll not suffer from nothing to do until we retire, and there'll be generations after us that also will be have a job because of this. So, because it is
for sure.
complex and it is complicated. So, but does this work for you, Richard? So I'll go grab the result list from the ticket, um, and I identify any gaps, and
Okay.
submit those to John, and for organism hierarchy codes if there's anything missing there. And then that way, also, though, we can identify all the substance concepts that are missing, and make that part of the longer project. And we could tell
Right,
carriers that, it'll be a little bit, ultimately they will get substance concepts,
right,
but not right now.
right. And then we'll probably, like I said, they're already reporting, I'm pretty sure, organism SNOMED codes to CDC already. So,
Mhm.
I mean, we would just probably be following that until everything in the longer project is more concrete and more standardized in a way that makes sense for us to consume it and process it correctly.
So they're reporting organism codes for an actual organism, not the DNA. Is that it?
No, they're
Um,
reporting the organism codes as answers to their test.
as of right now, they're not reporting anything to at least Florida. Like they're not set up yet with us. So we're in the process. We were in the process of onboarding them to our ELR system, to our surveillance system, and via ELR. But then we started running into these things, and that's when we reached out to APHL and Ricky and everyone, and trying to see what everyone's thoughts on this was, because we know that in the future this will probably become more regular testing and will have to be reported to other jurisdictions eventually. Um, so we just wanted to know like a way to move forward
Hmm.
that would kind of set like a path to like getting there, I guess.
Yeah, I mean, that makes sense.
Yeah.
They've been around for quite a while.
Mhm.
you know,
I know,
and
but yeah.
I'm not sure why they haven't gone for FDA approval at this point, but
I don't know the answer to that one.
right.
Okay.
So can you just give me an example of how you'd like it to be reported? So if a Carius result comes up positive for
Ideally, right, we would want them to report the substance, so the DNA
the DNA,
fragment
yeah,
or RNA fragment that they, not the actual fragment, but the fact that they found
a
DNA or
fragment.
RNA from this organism
Yes,
Yeah.
that's what we would like. Yeah,
as a substance. I mean, that's the ideal
right,
report because that's what they found.
right. And then can you get clinical findings? You really can't, right?
No, so a clinical finding would also um and so from a clinical findings hierarchy perspective, like I'm detecting antigen, this antigen, but it could, or this like for MALDI, right? You could say it could be either this organism or that organism, right? Things like that would be in the clinical findings hierarchy from a SNOMED perspective because it's not an organism, or even if you're trying to speciate an organism that you grew up in a culture and you can't differentiate to the species level, you could identify the organism to a specific level.
Mhm.
um, that's really a finding because um, the organism is still what it is. It's just you
Hmm.
just couldn't
Can't go. You can't. Yeah, you
can
don't have that
go to
clarity.
figure it out, right?
Right. He doesn't get
Um,
that granular for sure.
and so if it's a matter of speciation, then you can pick a higher level organism concept to represent that. But if it's a matter of your method not being able to differentiate between two different kinds of organisms in some
Yeah.
cases,
Hmm.
Yeah.
then that's really not an organism, right? That's a clinical finding. Does that make sense?
So if my Carius result was just says Canada species, that would be a clinical finding, or would that still be a substance?
I
The
think that would still be a substance because it would be
Well,
candidate species DNA. I don't know. I mean, I don't know what their fragments look like.
Yeah.
So,
I think it's all very. I mean, this is super specific testing. I don't know if
yeah.
they would. They would be as broad as just the genus level. I think almost at least everything I've seen on there, like when we requested their targets and stuff, or like all the things that they could identify, I didn't see any, at least that I remember, that is genus level. Everything was speciated because
Okay.
it compares to fingerprints. But I think it's even more specific than the moldy because it's NGS.
Okay.
Yeah.
So okay, because it could
Yeah, I mean,
get
this
the
is
D.
this
Yeah.
this particular thing is more not carrier specific. This is broader, right? These are the
Okay.
kind of concepts every LIS, EHR, and surveillance system should be allowed to have in value sets for result values. And they shouldn't limit it to just one of these, which is what's currently the case. They often just create, a
Right.
single value set that they map against.
Hmm.
Yeah. And it's probably whatever the most broadest value set that includes the most in it.
Yeah.
Yeah.
Okay.
Yeah.
So then whoever's looking at the coding really can't tell what's going on. Is that the thing? Like they can't tell if it's real or not. Or I'm sorry, it's DNA, RNA, or
Currently, well, they can. So Carius uses a loin code
Yeah, I'll be in the loins. Yeah.
that says this is a microorganism of interest sequence. right? But here they're
Mhm.
using presence, which presence is only qualitative, detected or not detected. So this is actually maybe not the right one either.
Right.
So this should be like,
Identifier.
identifier. Yeah.
Yeah.
Okay.
So we might, we might need a new loin code for them to begin with. So,
Okay.
um, but you would look at the loink component to know whether you're getting the whole organism, like, or whether you're just getting bits and pieces. I mean, an antigen test also doesn't guarantee you have a viable organism, right? Same thing. You could find
Or
the
PCR. Yeah.
antigen fragment, but who knows if it's not a dead organism, but that antigen will still be there, right?
Right.
Yeah.
Well, that's why you can't use it after you've treated the patient because it hangs around for a little while. You
Yeah.
can't use molecular testing either because it
Right.
hangs around.
Like after antibiotics or something. Yeah.
Yeah,
Right.
right. Yeah.
Yeah, because how we map everything, we map all of our test types by the LOINC.
Mhm.
So for Florida, like that would just go to sequencing, and then it would receive the sequencing test type, and then the organism would slot it into the Florida disease code, and then also give it an interpretation of positive. So that's how we would map that test.
Yeah. Okay, so it looks like we need to so I'll look into that too, as part of the ticket. Okay, let's see. We got 8 minutes. Nancy, I know you were on the EOC for
Mhm.
hantavirus. Um,
Hanta and Ebola. Hanta's
Ebola,
what
right. Right
is.
now, the next topic is about the
Oh,
Andes virus, so
okay.
the hantavirus, though. And
Okay.
so Andrea wrote a LinkedIn article, and I'll link that in here, where she basically looked around for both Andes and Ebola codes in the different code systems and whether or not they were available. And so Loink had just released their pre-release Loink codes, so those were available. Whether they don't currently cover everything, so like the Nebraska PCR is actually more specific. So, um,
Bye, Richard.
um,
See you guys. Thank you so much.
oh yeah,
Thank
sure thing,
you.
Richard. Thanks for joining. Appreciate it. Um, and so and for Ebola, I haven't actually done much of the analysis, but Christina and I are working on the Livet file for the hantavirus testing to be able to publish that.
Hmm.
And so we submitted loin codes that, for some of the tests that weren't yet in the pre-release. But she also looked at SNOMED codes, and there is a Andes virus organism hierarchy concept that's there. But there is no code that says this is Andes virus disease or something, right? But there are some other codes, like Andes virus, I think mainly causes the pulmonary um,
Right.
uh, PHS,
Yeah.
right?
Pulmonary syndrome. Yeah.
Yeah, sorry, I couldn't remember what the H
Yeah.
stands for, but
Yeah. Hantavirus pulmonary syndrome.
oh,
Yeah.
okay, that way.
Yeah.
So it usually causes that, but that's under um the hantaviruses, so I'm not sure that works. So I think she um she mentioned that to John on the loin committee call, and then it basically she thought somebody magically would make a submission, but that's not how it works. So somebody needs to actually um,
So Nance, two questions. Are is Andes orthohantavirus a subtype of the hantavirus, or are they two separate strains of organisms?
Well, I think they're a subtype of the hantaviruses. There's a number of hantaviruses. I'd have to go back and look them up. Like there's Sin-Nombre and they're
mhm,
found in different parts of the world.
right,
And they cause different syndromes.
right.
So I think Andes hantavirus is the only one that actually sometimes can be transmitted, though it's very difficult to
Human to
transmit
human,
it
yeah.
human to
Right.
human. It takes something like a cruise ship to make it happen.
Okay, so in
Um,
SNOMED, we have the Andes orthohantavirus, which is in a separate genus from just the standard hantavirus
Yeah, here,
because
see,
okay.
they're two different families, and I want to make sure that the hierarchical structure for the organism is correct. So that's my first question.
Okay.
And
so
then
this is family,
yup.
Mhm.
and this
And
is so
then
they're even in different families in here. So if
yeah, you actually have to go up to the class in order to see it.
where do you want?
Because you keep going up, right there. That's the next level. So there's where we break. We have the Hantaviriridae, and let me see. So Andes exists there. Now, where does hantavirus fit in? Hold on, let me find it.
It's here. It's
So just the straight hantavirus is
here
okay.
it is.
So
This is
it's
what I
under
needed.
a
Sorry.
different family. It's completely under a different family and under a different class. So that's where I'm getting confused whether we have hantavirus classified correctly versus orthohantavirus. And then the next question, actually, if you go up, Ricky, can you just scroll up, not in that window, but yeah, in the
Yeah,
entire window. Yeah, you see here where it's enveloped single-stranded ribonucleic acid virus. So we're jumping from the family to something that's a non-class. So we're
yeah.
parting from the Linnaean taxonomy, and I don't know if that's correct or why that was done. Um, so that's my first question to get that corrected. And then looking at the hantavirus pulmonary syndrome, we actually have that associated with the Gina hantavirus. Does there need to be a Andes orthohantavirus pulmonary syndrome disorder concept created?
Those
Hold on,
are
Ricky.
very good questions.
Okay,
Um,
so Ricky, there's your yep, you found it.
Mm-hmm.
Um,
so hantavirus pulmonary syndrome could be associated with any any hantavirus pretty much, as far as I remember. So
Yeah, but
that's not
but
this is
according to SNOMED, orthohantavirus is not a type of hantavirus.
it's not in the genus hantavirus.
Right.
okay.
So that's why this modeling wouldn't work to use that.
Correct.
Hmm.
Well, so we have to decide uh how we're going to approach this, right?
Well,
Are we I would have to talk to a hantavirus expert to
yeah,
Okay.
figure out.
maybe I was gonna bring it up and then maybe I need to send an email to the guy in New Mexico, Bradfute.
Is that his name? Yeah.
Yeah, yeah.
Okay. Yeah. I mean, I would talk to the expert
Okay.
because pretty much we're not really talking about this. We're just talking about how do we deal with patients where there might be possible transmission? How do you stop that? What does it take? Right.
Yeah, okay,
Um,
got it. Hmm.
and
Is there an ICD-10 diagnosis code that is specific to the Andes orthohantavirus version of the
There is
syndrome?
no ICD-10-CM. There is an ICD-11 code is the other thing that Andrea found.
Yeah, that doesn't help. Okay. All
Yeah.
right. Okay.
So that's, yeah.
Yeah, so I don't know, Ricky, what you need me to do to help. I mean, I can explain from a SNOMED side what the problem is. I just need a subject matter expert to be able to resolve it.
Yeah, John, maybe you and I can get together, craft an email to Bradfute, and I don't remember his first name now, but I can get his contact information. He's in New Mexico.
Okay.
Um, and and then we can see if we can at least get the organism, you know,
Hmm.
that piece figured out. And then once we have that figured out, then we can look at the disorder codes that we might need to fix or request new ones or whatnot.
Yep, exactly.
Yeah. Okay. I will draft an email um and and then you can help me
Yep.
clarify it and stuff. So
Yeah, even if you just want to send me his contact information, I can draft the email because I can explain the SNOMED side probably a little bit better.
okay. So how about
Um,
this? How about I set up an email chain between the three of
yep,
us
perfect.
and then you can explain the problem. And I'll
Okay.
I'll I'll link Andrea's
Yep.
LinkedIn thing as a, this is how it all started. So
Yeah,
Okay.
because
That
like
sounds
this is
good.
the first time this has ever
yeah,
happened, right?
yeah,
So I don't think it's ever been addressed. I mean, there has been documented transmission human to human in South America.
yeah.
Um, Not a lot of it, right?
No, but there
Um,
were some outbreaks in South America. There was at ASM there was a session about that, and Dr.
mhm.
Bradfute had that in part of that in his session. Yeah.
Okay, yeah. I mean, like I said, that just hasn't happened all that often,
Hmm.
and then
Right.
to have it happen like this is
Highly unusual. Yeah.
unprecedented.
Yeah. Yeah. Okay. Excellent. Well,
Okay,
I guess we'll talk next week, same time.
okay.
And we
Oh,
got some to-dos.
I I won't be here. So I'll
Okay.
be on annual leave for this coming up Thursday and the following Thursday.
Okay.
Okay.
All right.
Nice.
Thanks. Enjoy.
All right. Well, it's for my mom's memorial service,
Oh,
so
I'm
Oh, I'm
sorry.
sorry.
yeah. Um, but yeah, it'll be good to everybody getting together. So,
Yeah. I'm so
okay.
sorry. All
Well,
right.
yes, thank you. All
Hang in
righty.
there.
Yep, I will. Thank you.
Okay.
Bye bye.
Bye.
Bye now.